Good morning, everyone. So I hope you had your first cup of coffee. I didn't. I came just from vacation, so I don't need it for those who are jealous. So bear with me. I will try to take you through a small introduction of why Helios and why we had the great invitation today, and thank you again for that to present. The Helios Health Institute, for those of you who don't know it, we are part of the Helios Health Group. This is the biggest hospital operator in Europe. We have more than 140 clinics. We have more than 300 outpatient clinics and centers in Germany, Spain, and quite recently in South America. And we treat about 22 million patients per year. Now, this is quite an interesting landscape for you to think about, because contrary to the common belief, Helios actually is quite a heterogeneous environment, which means if you would like to integrate a digital health innovation, good luck with that. This is quite a challenge, so you would have to bear with us, and my colleagues can testify to that. Nevertheless, this creates the perfect environment for when you actually want to integrate something into the clinical routine, to understand the different challenges of small or big hospitals, tech-savvy hospitals, or the very traditional ones. Now, we are here today because we have this beautiful landscape where one can work in, and with that you can create and understand evidence of economic value, of clinical value. What does that mean for the key opinion leaders? What does that mean for the patients? No? Our team directly, so the Department of the Real World Evidence and Health Technology Assessment, tries to create always a data evidence approach. So Helios loves its numbers. We're pioneers when it comes to the quality medicine. We developed the Initiative für Qualitätsmedizin in Germany. And through this mentality, we always try to understand what does that really mean for each solution that we try to bring into the clinical routine. We have quite a nice team here, mostly in Leipzig, Berlin, and somewhere around Germany. Quite a lot of different fields and professions. This basically sums up what we are trying to do, or what we are doing to create and develop the evidence. And in the past years, we have become quite successful in publishing also our results, which I consider to be also one of the key aspects of adoption of clinical innovations. I'll come back to that later. Now, in case my name, accent, or appearance didn't give that up already, I'm Greek, so bear with me with the Socratic method. I'd like to ask a few questions. Now, health technology assessment. How many of you have actually developed your own solutions here? Maybe you lift up your hands. How many of you have actually done a clinical study to prove the clinical evidence? Fewer hands. How many have done a study to actually see if it's adopted into the clinical routine? So not just the clinical validity. Okay, I see one hand, two hands now. This is actually bringing the biggest topic, the big gap. It's one thing to discuss about how clinically great your solution is, and it's a different thing to actually see if people want to use it. And I pose here a very interesting article and the reference to the study that they did in the US. They understood that there is a huge gap in what they call clinical robustness. That's a score that tries to show claims in the FDA about clinical value, economic value, and user engagement. And mind you that the clinical robustness score, can go up to 30, and most of the companies, if you see, had actually a clinical score of about 2.5. About 70% of them actually had less than 2. So that's where we stand. And the reality is that people develop solutions without really taking into consideration what does that really mean for the people who are going to use these innovations. Now the nomenclature, I think this is important as to what we said before, difference between approval and adoption. And I already spot a small mistake in the adoption. So the approval is what we perceive for the regulatory landscape. So I need to as you might already know, to create an intended use statement, go for the demonstration of safety, and then at the end present the FDA, for example, with a clinical evaluation report. And this shows the clinical association, analytical validity, and clinical validity. On the other hand, adoption is all about the value proposition. You need to make a claim as to why this is valuable for the clinical routine. Then you actually need to demonstrate the value. And then finally, you go to the implementation and assessment report, which is the painful road to actually integrate into the hospital information systems, to actually integrate it into the clinical routine, educate the physicians, for example, to use it, and so on and so forth. No? Adoption is actually a constant struggle, and it's an iterative approach. That means that you need to understand that at any given point, you create your value hypothesis, you design how you're going to test it, you find the proper environment, you do all the appropriate tests, you measure adoption, and then you get the results back. And then you reiterate again and again and again, so that you constantly improve your product, because as you've already pointed out, there are a lot of problems and issues in healthcare, and people are constantly trying to improve it, but that means that you also need to constantly adapt. Now, this is our approach in Helios and via the Helios Health Institute, how we try to measure adoption and integrate innovations. We have 5 or about 15 of stages of health technology assessment. Now, we start with the idea. Contrary to what the common belief is, people tend to start actually with the MVP. This is, in our opinion, already too little too late. You would need to reach out to the people, the experts who are going to use it and who understand what the clinical routine looks like already in the very beginning. And that's why we would be doing a pathway analysis to really understand the pain points and where you should integrate the solutions. Then you have the concept, and once you develop the concept, you would go and discuss it further with the key opinion leaders, and if it's relevant to the patients, also with the patient groups. Then comes the MVP, and there we would go with the technical implementation. So a very clear example. We had in Helios many times people who came with a very ambitious plan to integrate a cloud-based solution. That would have been great for us to do, but unfortunately Helios is not on the cloud. And if you're trying to get a big market share with the biggest hospital provider in Germany, for example, then you're already losing the game from the very start, because cloud, and due to the GDPR, the very, very strict GDPR that we have in Germany, we are not that easy to integrate to. So welcome aboard to the Helios world. Then you have the UI UX testing. This is not as technical as people would think about. It's more about really understanding, is it easy for me as a physician to click a button when it comes to my hospital information system? Do I actually need a notification? Do I like getting a notification? Stuff like that, yeah. Then we would proceed with a clinical study. This simulates perfectly how things would work, no? And finally, all these results we would try to publish, and this is the publication part, launch to the market, show the world what we did, what we found out, and then receive the feedback to again reiterate our approach. From these 3 or 5 steps, I picked out 3 that I would like to stay on and explain a bit later. That is the pathway analysis, the UI, UX testing, and this real-world evidence, and actually producing the evidence and publishing them. This is what the pathway analysis looks like. So we would say that if somebody wants to really understand how to perform a proper clinical integration, not just technical one, you would need to understand how does a senior physician perceive your software, for example. How does a junior physician perceive your software? If it's being used by a nurse, does the nurse actually have the time to do it? At which point do they have the time to do it? Which time, which patients, and so on and so forth. So you would, starting from left to right, you would need to really understand the pain points. You would really need to understand the concrete steps, develop your KPIs, and then once you have that, go with this very objective approach back to the key opinion leaders and say, hey, you told me that you actually perform an echocardiography before ablation, like a clear example, at this point, but actually our data show that you do this at this point. So why is that? And then you need to understand this gap in the information. And this basically explains the structure approach. I will not get that much into it. Now, the UI UX testing, this is a question that we usually get from most of our partners. So why or how do you measure that people really like to work with your product, and how would you measure that? And for that, there are multiple questionnaires that one can use. We like this set, and we've already established it in a project, and probably continue to do so, because this is basically similar to the clinical robustness score, allows you to understand, is the software easy to use? Do people like to use it? Do people trust in the results that, for example, the software is producing? No? And this is again a very concrete way to actually get measurable outcomes and develop your KPIs. The next is about the clinical studies, and aside from me bragging about us being the first ones to actually establish such a platform, the use of this slide is to show that once designing an experiment to actually measure adoption, you need to be sure that you have the right people and the right setting. And for that reason, we have developed and we are using a platform that allows us to also have the clinical evidence before we even try to get the clinical evidence, meaning that we already know the patient flow, the outcomes, the routine before we go into the setting and establish the pathway analysis, do the interviews and talk with the experts. No? And finally, just a very quick run through. This is how we try to then publish the findings and get it out to the world. So actually we get the feedback from reviewers, from other people who have read our papers, to understand if what we try to integrate is valid with what is happening out there. And this is a very clear example. So there we were actually very consistent with what we saw. In studies in Germany and France, UK and France, we found out that the elderly population, heart failure and with atrial fibrillation, are actually not that prone into using mobile-based solutions. And we tested that and found out that this is consistent. Actually, most of them are willing to do paper-based, so welcome 1981, or web-based. Which means that from the very beginning, if you're trying to develop a concept of outpatient monitoring, you might have to actually take into consideration that you need to go with a web-based approach, regardless of how fancy it might sound to go with mobile-based. And the same applies here. So we also had some interviews with physicians. We wanted to use the Apple Watch in the Heart Center Leipzig here. It's one of the biggest cardiological centers worldwide. And we found out that physicians were not that prone to do so. No? And the reason was that nobody had actually done what we did, to actually test and develop a quasi-Holter ECG, which is what we did with the Apple Watch, and developed the evidence. And now most of our departments in the Heart Center Leipzig are actually trying to use the Apple Watch or smart devices, because now they actually have the evidence for it. And this is the importance of actually publishing your results. And this is just very quickly on getting out there. How would you develop such an environment to establish a digital infrastructure for cardiovascular patient care? Again, as you can see, this is quite a complex approach that involves a lot of steps. No? Now, just to not forget, this is to be repeated. Where is Thomas? Thomas is not here, so this is the old presentation. Just to remember that you always need to go through this constant circle. And my favorite thing of the day. So the reality of adopting innovations is painful. So there have been so many times that we've seen some adherence, for example, helpers that are based on sending reminders, and the patient simply says, I don't know, I don't care, I don't do it. No? Or the fact that you think that you will disrupt the healthcare industry with the most complex algorithm, and all you need to do is just do this pathway analysis and understand that all doctors need, for example, are simple education, 2 buttons, and then you're done. So that's it from my side. Thank you for the time. If you have any questions, please find me later. As I understood, we're not going to be doing that now. So thanks again.